Is the microphone working? Can people hear me? Oh, perfect. Okay, I think the microphone's working, so I'll just leave it a couple of minutes to let people join, and then we'll get started, all right? Okay, so we'll aim to start at 5 past for everyone that's joined so far. Okay, so I'm going to make a start. Today's session is on testicular conditions, so this is part of the UK MLA series, and I'm Amelia Simenacz. I'm one of the foundation doctors at the moment based at the Royal Free Hospital in London, and I am the urology lead for the UK MLA series. So let's get started. So just quickly outlining the UK MLA map. So I've just been taking... Oh, sorry, I think my microphone's just disconnected. One sec. Okay, so for some reason I'm not sure that's working, but let's go ahead anyway. So taking a look at the UK MLA map, I've just tried to outline a few of the key points that we'll be going through today. So mainly looking at scrotal and testicular pain, epididymitis and orchitis, and a brief outline of testicular cancer. These things seem to come up in finals all the time. They're quite high yield topics, so definitely worth getting your head around the basics and nailing them first time really. So just an overview of our session. So like I mentioned, we're going to talk about testicular torsion, and I'm going to briefly touch on torsion of the appendix of the testes as well. I'm going to look at incarcerated and strangulated inguinal hernias, epididymorchitis, have a look at scrotal lumps, so that's mainly hydrocele, varicocele and epididymal cysts for UK MLA finals, and also have a look at some testicular cancer questions as well. Before we get started, I just thought it was worth us having a quick think about the history and examination for these urological conditions and testicular lumps. So let's go through it. Examination findings. So things we're looking for in the testes. Is it high riding or does it have a transverse lie? So first things first, get your patient to strip down, take their underwear off and fully expose the patient. So it can feel awkward initially, but you quite quickly get comfortable with asking patients to do this. Always ask for a chaperone with you and make sure you're fully examining the patient. You're not going to spot the diagnosis if you've not examined them properly. So like I said, high riding or transverse testes, if they've got a cremasteric reflex, can actually be really hard to elicit, but definitely worth giving it a go. If there's any scrotal skin changes, so there might be erythema, so redness, it might look swollen, might look necrotic, so that's when the skin looks black, and there might be crepitus. And we can also do friend sign, we'll touch on this later as well. Main things we want to do is a primary survey and also look for red flags. So for example, in their observations, we're particularly interested in if they've got a fever, if they're tachycardic, so if their heart rate's elevated, and if they're hypotensive, so has their blood pressure dropped. I guess these things, they tell you early on if the patient's compensating for their presentation and how acutely unwell they are and where they need to be managed. Most patients won't need a resus setting initially, but these are some of the things to look out for. Then the main thing is pain onset. So is it sudden onset? Is it severe? Is it nocturnal? Is it waking them up from sleep? Again, very important to ascertain. And we want to investigate the associated symptoms. So are they vomiting? Are there any genitourinary symptoms? So have they got discharge, pain on passing urine? Is there any abdominal pain associated with the testicular condition? And again, are there any skin colour changes or crepitus presence? So let's start with testicular torsion. Always seems to come up in finals. Very important that everyone knows about it, and it's a urological emergency. So testicular torsion is when the spermatic cord twists and you get rotation of the testes. It becomes necrotic, as you can see, and your testes essentially dies. Time is testes, so very important we take these patients to theatre immediately. A scrotal ultrasound can confirm the diagnosis, but delays can lead to delays in theatre time. Classically, you might see a whirlpool sign, so the spiral appearance of the spermatic cord and blood vessels. Usually in A&E we don't end up doing any ultrasounds because just delays time to theatre. So if it's clinically thought that this patient might have a testicular torsion, they're taken straight to CPOD theatres for emergency testicular exploration. So the typical presentation, and these are the key things that will come up in finals. Again, every patient presents differently, and this is not the be-all and end-all, but for finals and for the typical presentation, these things are worth knowing back to front. So it's typically younger males, typical age is about 12 to 18, and can be triggered by playing sport. I might say that in the short stem of questions. It's a sudden onset pain, one-sided, unilateral, usually at rest, or can happen at night. Patients are often in that much pain that they're nauseous and they're vomiting. They might have some associated abdominal pain, and they might have the high rising horizontal testes. So you'd be able to see it when you ask the patient just to examine them before you even start palpating. They might have diffuse tenderness. Classically, they won't want you to examine at all, and even examining the testes will cause them significant discomfort. And they'd have a negative friend sign. So when you lift up the testes, the pain won't improve. And at this point, I think it's important to highlight, so if there's any doubt or suspicion of a torsion, then immediate senior urology opinion is needed. So again, highlight early the red flags. In children, sometimes it can present just with abdominal pain initially and then go on to produce testicular pain. So anyone with abdominal pain, we should also be examining the testes to make sure we're not missing any pathology early on there. Having a quick look at the bell clapper deformity. So common cause of testicular torsion. So normally the testes is fixed at the back to the tunica vaginalis. But in a bell clapper deformity, the fixation between the testicle and the tunica vaginalis, as you can see in the image there, is absent. So the testicle hangs horizontally instead of the normal vertical position. It means that the testes is able to rotate within the tunica vaginalis, and you get twisting of the spermatic cord, and that can cut off the blood supply. Okay, so I thought I'd mention torsion of the appendix of the testes. This can sometimes come up in MCQs, and it's typically stated like a blue dot sign. So as you can see, there's like an appendix of the testicle there, and that can twist, and you get a blue dot sign. Management is different to torsion. You normally manage it with pain relief and scrotal support. We don't often do surgery unless the diagnosis is uncertain or the pain is refractory, so it's not improving to simple painkillers. That being said, can be very difficult to distinguish, so some of these patients do end up going for scrotal exploration. But yeah, this picture on the left is when the scrotal explorations happened, and then the right is just a schematic of a cartoon to make it simple to see. So what's the management? Our management is an emergency, so it's a urological emergency. We're going to get the urology team involved early. Delays can cause ischemia, and so then that reduces the chance of the surviving and functioning testicle. We're going to make our patients nil by mouth very early on. We're going to give them analgesia, and then the surgical options. Two main options. So there's orchipexy, which is fixing the testicle, and then orchidectomy, which is removal of necrosis if it's present. Normally we fix both sides, so not just the side that's torted, we do the other side as well. And obviously if there's any necrosis, we remove it because it's a non-viable testes. And again, just on the right image there, showing that the spermatic cord is twisted, and that causes ischemia and then necrosis, so tissue death. Okay, so the most common differential that comes up in exams with torsion is epididymoarchitis. So epididymoarchitis is inflammation of the epididymis. And orchitis is inflammation of the testes. So as you can see on the image here, the epididymis runs like next to the testicle, and inflammation essentially causes a tender testicle, and it can be caused by multiple things, but mainly E. coli and chlamydia. Gonorrhea can also cause epididymoarchitis, as can mumps. With mumps, you'll get classical parotid swelling and maybe some pancreatitis as well, but I've never seen that in medical school finals, so I'd be thinking more E. coli and chlamydia at this point. Okay, so the typical presentation of epididymoarchitis, so it's more of a gradual onset of scrotal pain, you'll get swelling, you'll get a heavy dragging sensation in the testes. You might get some fever associated, you might get some urinary symptoms, so you might get some discharge, systemic features, so fever, sepsis. When we see them in A&E, we're going to do simple workup, so we're going to send their urine for urinalysis and MCS to try and find the bug that's causing it. We're also going to send them for an STI screen, mainly looking for chlamydia and gonorrhea, and a saliva swab if we're thinking of mumps. Most of these patients do end up getting a testicular ultrasound just to confirm it's epididymoarchitis. We usually send them home and bring them in the next day or next couple of days to do an ultrasound, just to make sure there's no underlying tumour or, I guess, to rule out a torsion. Some of the complications of epididymoarchitis, so these patients can develop chronic pain, chronic epididymitis, testicular atrophy, subfertility and infertility, and scrotal abscesses. But for the sake of exams, I guess infertility and chronic pain is the things that mainly seem to crop up from my memory. So management of epididymoarchitis, under 35 for MCQs, usually they think it's sexually transmitted. I guess it makes some assumptions, but that's usually what the questions seem to say. So we're going to give them ofloxacin or levofloxacin, and then if they're I've got that the wrong way around. And then if they're over 35, we're going to give them, we're going to assume it's E. coli, and we're going to assume it's enteric. Going on to treatments, the main treatment options for epididymoarchitis, we're going to give them antibiotics, we're going to give them fluids, and we're going to request an outpatient ultrasound. I thought here was just worth mentioning something about quinolones. So class of antibiotic, they cause broad spectrum cover, usually against gram-negatives, and commonly used in urology. So we use in UTIs, pyelonephritis, epidermolysis, and prostatitis. Side effects of quinolones seem to come up a lot in exams. So tendon damage and tendon rupture, especially the Achilles tendon, is one of the side effects. So if anyone's got a history of these tendon issues, we tend to avoid it. And also caution in epilepsy, because it does lower the seizure threshold. So things to be aware of when you're thinking about quinolones and when they come up in MCQs. So now let's have a quick look at scrotal lumps. Starting with hydrocele. So what is a hydrocele? Hydrocele is a collection of fluid within the tunica vaginalis which surrounds the testes. So on the image right here, you can see there's just a collection of fluid. Usually they're painless, they're fluctuant, so they can vary in size. They're soft, they're irreducible, they don't have bowel sounds when you listen to them with your stethoscope, which differentiates them from hernias. And sometimes you can palpate the testes within the hydrocele. In MCQs, they typically transilluminate, so you put your torch on them and they transilluminate. That's usually the key buzzwords that you're thinking of. Causes, so they can be idiopathic, so no apparent cause and just happen, but they can also be secondary to certain conditions, so you can get a hydrocele after secondary to a testicular cancer or a torsion or an epididymitis or trauma. So worth thinking about these things when a patient comes in with a hydrocele. Then varicocele. So varicocele, we've got some veins in the pampiniform plexus. So we can see on this image here lots of veins, and they become abnormally swollen in the varicoceles, usually due to incompetent valves in the testicular vein. So you get backflow, and then these veins swell, and they cause a bag of worms. I've got another picture on the next slide. Very common, affects about 15% of men. Usually we leave them alone unless they're causing impaired fertility. They can disrupt the temperature, and so they cause testicular death, and then they reduce the size and function of the testicle. So on the left is normal veins, on the right you get these swollen veins in the testes. Okay, so then I thought let's have a quick brief look at the anatomy. Again, can come in MCQs and useful to realise why it's happening really. So on the right here is an image of the venous drainage of the testes. So on the right, the testicular vein drains directly into the inferior vena cava. But on the left, it goes via the left renal vein. So left testicular vein, left renal vein into the inferior vena cava. 90% of varicoceles do occur on the left, and they're due to increased resistance in the left testicular vein. And it can indicate that there's an underlying RCC. So if someone's got a new sudden onset left varicocele, we're thinking, let's go and get an ultrasound scan just to make sure they've not got a renal cell carcinoma. So I've just highlighted here the teaching points at a large sudden onset. Varicocele in a young man is a red flag, and we want to rule out any renal vein or inferior vena cava pathology. So hopefully this picture will make you always think of varicoceles, a nice big bucket of worms. So they're typically called a bag of worms in MCQs. So on examination, we're going to get this dual throbbing pain, and it's usually worse when the patient stands up. They might get a dragging sensation, hematuria, subfertility and infertility, and like I said, a scrotal mass that feels like a bag of worms. Often more prominent when you stand and then disappears on lying down, all due to venous drainage. We're going to do an ultrasound scan for these patients, usually with Doppler, and that confirms our diagnosis. Don't routinely need to do it, but we'll do a semen analysis if fertility happens, and then some hormonal testing if we're concerned about function of the testes. So management of varicocele, typically we just leave them, they're managed conservatively. If they're causing problems or fertility issues, we do surgery or endovascular embolization. Okay, so epididymal cysts. So epididymal cysts occur at the head of the epididymis, so that's the top of the testicle. They're typically a fluid-filled sac, and epididymal cysts containing sperm are called spermatoceles. So you can't clinically differentiate spermatoceles and epididymal cysts, but it's just the contents of them. Epididymal cysts are very common, happening in about 30% of men. Most are asymptomatic, and they're found incidentally on ultrasound scan. But on examination, we feel a soft round lump at the top of the testicle, and it's usually separate from the testicle. you might be able to transilluminate large cysts. So when you shine a light through them, usually they're harmless. They're not associated with any infertility or cancer. They can sometimes cause some pain, and that's when we might consider removing them. But usually we just leave them alone, and rarely they can cause torsion of a cyst, causing acute pain and swelling. Okay, testicular cancer. So testicular cancer typically arises from germ cells in the testes, and germ cells are cells producing gametes, so that's sperm in males. There are other rare testicular tumours, so non-germ cell or secondary metastases, but I wouldn't worry about these in terms of UK MLA finals. Focus on the high LG diagnosis. So mainly divided into seminomas and non-seminomas, and non-seminomas are mainly teratomas. Risk factors for testicular cancer: young males, usually they're between 15 and 35 years old, so it's with young males. You get if you've got a previous undescended testes, that increases your risk of testicular cancer. If you've got male infertility, a family history, and weirdly increased height is also a risk factor for testicular cancer. But for the purpose of finals, I'd think about young males and if they've had an undescended testes as a child. Okay, testicular cancer. So we're going to do a scrotal ultrasound initially. That's the first line when we've got a testicular mass that we're not sure what the diagnosis is. Usually we also order tumour markers at the same time. So the main things we're looking at is AFP, beta-HCG and LDH. For the purpose of finals, I've tried to simplify it. So AFP in teratomas, beta-HCG in both teratomas and seminomas, and LDH is a very non-specific marker. The markers do tend to come up in finals, and it's worth knowing the simple facts that can get you the easy marks. Common sites of metastases, so we get metastases to the lymphatic system, to the lungs, to the liver, the brain. They're common sites. So symptoms of testicular cancer, usually it's a painless lump in the testicle, can cause testicular pain occasionally, but typically it's painless. Usually non-tender, arising from the testicle. You can palpate it directly within the testicle. Hard, irregular, non-fluctuant, doesn't transilluminate. Some do get gynecomastia, but a very small number, only 2% of men with gynecomastia have a testicular tumour, but worth mentioning. So what is the management of testicular cancer? So there's a good prognosis with testicular cancer. I've got 90% cure rate. Metastatic disease is often curable, not always, but often. And follow-up mainly involves tumour marker monitoring, CT scans and chest x-rays. Surgery, we're going to likely do a radical orchidectomy, followed by chemotherapy, radiotherapy. Sperm banking is also an option to save sperm for future use, because treatment can cause infertility in these gentlemen. Some of the long-term side effects of treatments, so can cause infertility. Previously, that's why we mentioned sperm banking. Hypogonadism, so you might need testosterone replacement. You might find you get peripheral neuropathy, hearing loss, lasting kidney, liver or heart damage, and an increased risk of cancer in the future. So I thought it was worth doing a couple of MCQs and just highlighting exactly how you distinguish what the diagnosis is, because it can be difficult to know when you're faced with these exam questions. So we'll start with the first question. I'll read it out. It's probably easier for us to then give you a minute to think about it, and then we'll go through the answers. So first question, you've got a 48-year-old man and he attends your GP after finding a new lump in his scrotum. He noticed it a week ago. During self-examination, he was in the shower. He denies any recent trauma. He's otherwise completely well. He's got no significant medical or surgical history, and he's got a regular sexual partner. Observations are in normal ranges. His tummy's soft and non-tender, no signs of inguinal hernia, and he's got a small non-tender palpable mass just posterior and separate from the body of the right testicle. Left testicular exam is normal. So what do we think the most likely diagnosis is? Okay. So this question is an epididymal cyst. So it's the main reason we're thinking epididymal cyst is it's palpated separate to the body of the testes. Just going through them. So varicocele, we say classically bag of worms. Hydrocele, it's not separate to the body of the testes. It's not a hard lump like a tumour. So we're thinking epididymal cyst. Okay, question 2. So now we've got a 33-year-old man, and he presents with a 2-day history of gradual onset pain and swelling in the right testicle. So 2-day history. Pain's described as a 5 out of 10 on the pain scale, and around 4 weeks ago he returned from a holiday in Spain, but he has no dysuria, so burning on passing urine, or urethral discharge. So on examination he has a tender swollen right testicle, his heart rate is 84 and his temperature is 36.8. So what is the most likely diagnosis? Okay. So this one is epididymoarchitis. I think let's talk through the main reasons why we're thinking epididymoarchitis. So 5 out of 10 pain, not 10 out of 10 pain. It's a gradual onset. It's happened over 2 to 48 hours. He's not compensating, so his heart rate is 84 and he's apyrexic, normal temperature. If this was going to be torsion, the question would have explained a more acute onset, so it would have been it wouldn't say things like gradual onset of pain, 2-day history. It would be a much shorter history and a sudden onset of pain. The gradual onset supports epididymoarchitis over torsion, and you'd get more severe symptoms in torsion, so the pain would be classically more than a 5 out of 10. Obviously, every patient's different and not everyone presents classically, but in terms of MCQ questions for finals, those would be the key things that we'd be thinking about. So final question. So we've now got a 3-month-old baby boy, and he's being reviewed for his GP for an undescended testes. Left testes was found to be undescended during his NIPE, so his newborn examination, and today only 1 testicle is palpated in the scrotum. He's referred to the urology surgeons for review. And now the question to ask is, what complication is this patient at increased risk of developing if the abnormality is not corrected? So I'll give you a second just to read through the options there. Okay, so answer for this one is testicular torsion. Undescended testicles are commonly associated with an increased risk of infertility, torsion, and testicular cancer. So worth thinking about not only the risk factors for torsion, but what those complications might be if we don't surgically fix them. Great. Has anyone got any questions? So I don't think anyone has any questions. If anyone has any questions about the PowerPoint or about F2 in general or urology, just drop me an email. I think my email will be found on the Mind the Bleep Instagram page where the session was advertised. I'll be more than happy to answer any questions or give advice if anyone has anything. But yeah, have a great weekend and thank you everyone for listening.